Hello, I'm Dr. Lee. Welcome to my image training channel of practical pain management. For chronic cervical pain, I have used two image guiding modalities. One is ultrasound and the other is CM. In cervical radicular pain or radiculopathy, I use ultrasound in case of paracentral or lateral disc herniation and foraminal stenosis. But in case of central protrusion or intractable pain to the ultrasound guided procedure, I choose CM. In axial neck pain due to discogenic or discitis, I prefer to use CM instead of ultrasound. In this video clip, I'm going to talk about ultrasound-guided cervical extraforaminal periradicular steroid injection. Please keep in mind, the target of the ultrasound-guided procedure is not the same as the CM-guided procedure. The CM target of transforaminal selective epidural steroid injection is the internal aspect of bony intervertebral foramina and epidural space. It aims to spread the contrast media into the internal intervertebral foramina and epidural space, expecting steroid effect in the same area. Ultrasound target is an extraforaminal perineural space, not the bony intervertebral space. This is inevitable because there is a physical limitation of ultrasound transmission and image producing technology. Let's watch the histology of the cervical nerve root specimen. The nerve root consists of several large, round fascicles. It is very homogeneous and contains abundant water contents. The picture in the center is the nerve root on real-time scanning of the neck. The ecotexture of the nerve root consists of several round hypoechoic structures. I wonder the reason for this ecotexture in 12 years ago. So, I harvested cervical nerve root specimen from fresh cadaver and put it into the fresh water. It shows the same ecotexture as the real ultrasound scanning. Reflection in ultrasound refers to the return of the ultrasound wave energy back to the transducer. This principle is what allows the image to be generated by ultrasound machine. The ultrasound beam the tissue interface with a larger difference in acoustic impedance will result in a large amount of sound energy reflection and cannot penetrate further. So we cannot see the inside of the bony intervertebral foramina. Anisotropy is the most significant and commonly encountered artifact in musculoskeletal ultrasound. The anisotropic artifact refers to the darkening and loss of resolution of the image, which occurs when sound wave approach is less than perpendicular. This ultrasound scan image is a transverse scan outside of the foramen. The hypoechoic nerve root is seen between anterior and posterior tubercle. When moved up cranially to catch up the proximal part of the nerve root, the hypoechoic nerve root is sinking into the darkness. If I try to scan the more central portion of the nerve root, it became harder to differentiate between structures. In the upper level, nerve root could not be discernible to an adjacent hypoechoic structure made by reflection and anisotropy. In the level, we cannot tell which is the nerve root and perineural structure. If we insert a needle at this level, the needle tip could reach the vertebral artery. When we inject local anesthetic into the vertebral artery, the consequence is fatal. So target should be extraforaminal periradicular space in the groove between anterior and posterior tubercle in C5-C6 root. Needle tip should be placed in between the nerve and transverse process in the C7 root block. Let me introduce my patient. He is right scapular, deltoid pain, tingling sensation and numbness of the second finger. He showed a positive sign on the Spalding test. His X-ray shows degeneration and foraminal stenosis at right C5-6 and C6-7 level. It is sagittal, oblique sagittal, and axial T2 weighted image. Oblique sagittal image shows foraminal stenosis at right C5-6 and black disc protrusion at C6 and 7 level. So I select a target at C6, 7 root and decide to use ultrasound. What I put in each level, I put 0.5 ml of 2% mepivacaine, 1 ml of 30% of dextrose solution, and 1 ml of dexamethasone palmitate. I always put 1 ml of iohexol contrast media at one level. Before the injection procedure, I need to full search out all the anatomy. I have to find several nerve roots and vascular structures. This scan is a transverse scan at the area of C6 root. Anterior tubercle of C6 is very prominent, but anisotropy makes it challenging to identify. Search the anterior tubercle very carefully. Posterior tubercle is relatively perpendicular to the ultrasound beam, so it is not difficult to find linear transverse echogenic posterior tubercle. Single or several hypoechoic neural fascicles of C6 root can be found in the groove. If my needle approaches close to the neural fascicle, I need to slow down and move very slowly, but introduce the needle tip near as much as possible. But I try not to touch the neural fascicle of the nerve root. Frequently, I use the hydrodissection technique to separate the tissue and fascias. This scan is a transverse scan at the area of C7 root. Transverse process looks linear echogenic line and it has no anterior tubercle. I can find the C6 nerve root arising from the floor. Again, if my needle approaches close to the neural fascicle, I should the needle move very slowly. Sometimes it is challenging to differentiate between C7 nerve root and vertebral artery. So at C7 level, we have to watch out vertebral artery in addition to C7 nerve root. C7 transverse process appears linear echogenic line, and my needle approach anterior to the transverse process and posterior to the neural fascicle. I need to confirm and verify my procedure with the contrast media. I use 1 ml of iohexol, and iohexol is sold under the trade name Omnipac. One of two targets, I infiltrate contrast media only one level. This is a C7. Nerve root can be recognized as a filling defect. Thank you for your attention.